Hello, everybody. So nice to see so many people in the room. Welcome. Just to make sure that you're in the right session, you're at PSR Best Practices, What We Know. And today is February 13th. So welcome, everybody. Just a reminder who your team is. I have Matthew sitting to my left. Thank goodness. He's the man who keeps us on track with our technology. To the left of that, we have Jordan Clark, who is our technology support person who's built this platform, and we're deeply grateful to him. He continues to support us with the evaluation process and many other ways, so we're very grateful to Jordan. Not sure if you're on the line today. Bottom left-hand side is Dr. John Higginbottom, who really designed and thought about this program. So I know John was hoping to pop in today, so welcome to John and myself, Regina, that you hear from regularly. So a warm welcome to everybody out there. We have people from Manitoba, we have people from all over the place today, so we welcome you. We know that some places in Terrace are snowed in, so really nice to have you here. We wish you a warm welcome. So you'll know that this work is funded by the Ministry of Health that provides leadership, education and guidance to the mental health field to help develop and put effective evidence-based psychosocial rehabilitation practices into place. So we're very grateful to our instructors. We also love to hear from you. Should you wish to present, please let Matt or myself know. Many of you are engaged in super powerful programs that we'd love to hear about. If you have any interest in presenting and sharing with your colleagues your best practices, we'd love to hear from you. The purpose of the advanced practice, you'll know, is really about just transferring the evidence-based knowledge, and we provide some expert clinician consultation should you be interested, training and education events, developing our website resources, and supporting the Provincial Advisory Committee and the Committee for Community of PSR Practice. So we're here to be a support from you, and we love to hear from you. We also just want to remind you about our upcoming conference. It's called Building on Hope. Please do save the date. We'd love to see you there. We've heard from many of you who'd like to do some presentations, but we hope that you can join us in sunny British Columbia, June 16th and 17th. You'll also remember that June 15th that we will have some institutes. Dr. Mary Jansen, who's with us this morning, has kindly agreed to do an institute for us. She is one of 6 institutes that we're hoping to offer you on the 15th of June. And then the 18th, we will have a one-day symposium, half of which will focus on housing and the other on employment. So it promises to be a very exciting educational opportunity for those of us interested in psychosocial rehabilitation. So we need you. Come play with us, and you will see the registration on the PSR website. So we really encourage you to have a look at that, and you'll see Sherry's email at the bottom of the page, sherry@innovative4u.com. So give Sherry a shout if you have any questions or you're interested in signing up. So that's a little bit about our conference. And then just back to today's presentation, you'll remember that it's one in a series of 6 funded by the Ministry of Advanced Education. So we're grateful to them for being able to provide this education, the funding for this education today. And on this next slide, you'll see that that's us today, February 13th, in preparation for Valentine's Day tomorrow. We are getting some good information. And then please remember, we have one more session by Catherine Newstead coming up. So love to see you on the 27th. And just to remind you that we really appreciate your feedback. Tell us how we're doing. Give us some information. We really want to learn how to better serve you. So please note that we will also be doing a 2-month follow-up on this particular series, just asking you how we did and how we could do better. So we really it helps us improve our performance. So thanks very much. And it is my sincere pleasure to welcome Dr. Mary Jansen to this session. We are very grateful to have her level of skills and expertise. You will see from this bio that Mary comes with a wealth of background and experience in psychosocial rehabilitation. She currently directs Bayview Behaviour Consulting here in Vancouver, BC, and I know she advises many agencies and health authorities about rehabilitation and recovery services for people with serious mental illness. And having been engaged in a couple of those projects, I know that Mary has a lot to help us and to guide our practice. So Mary's originally from the US, so you'll hear a little American accent, which is always charming. And she was the Deputy Chief Consultant for Mental Health and Chief Consultant for Psychology in the US. So she comes with just so much background. You'll see further down in the bio that Mary also has experience working with the World Health Organization, first as a consultant to the Mental Health Department, where she's established a program to empower consumers of mental health services in WHO member states. And I'm just going to flick the page here to just point out one thing that Mary has recently co-authored with the APA Association, a series of very, very powerful lectures around psychosocial rehabilitation and recovery. We have left Matt kindly has left the direct link to that. It's called the Recovery to Practice curriculum. So it's a series of lectures, and she's even included some slides. So if you're interested in doing some education in your organization, that is free and open access, and it's just a real gift to our world, I think. So really encourage you to have a look at that site when you have a little bit of time. So Mary will speak to us today about IPS, and it is just, I'm going to hand her over to you right now. Okay.
Okay, well, thank you so much for that, Regina. That was lovely. I appreciate it. And before I forget to do this later, I want to also thank Matt for all of his technical assistance. Those of you that know me know I'm not the greatest with technology. So the next thing I want to do is welcome all of you to this and say, first of all, thank you for coming and thank you for allowing me to present to you. I appreciate the opportunity. I also want to say I recognized a few names from the list of people who are signed in. And so those of you that have been in the PSR program might recognize some of the material I'm going to present. So I apologize if it's redundant, but hopefully it'll be a good refresher. So I think the first thing I have to do is change the slide. Okay, that didn't work here. There we go. Okay, so we have 3 learning objectives for this session, and you can see them there. We will be going over all of the material related to the learning objectives. I don't know if there's a test or anything like that. No, there's nothing about that, I'm told. But we did have to provide learning objectives, so you will see them there. So we'll just go on. So the first thing we want to talk about is what really are psychosocial rehabilitation services, and more specifically, what are the categories of evidence that lead us to believe that psychosocial rehabilitation services, or at least some of them, will work. And the reason I put this information in this presentation is because I was specifically asked to speak about supported employment as an evidence-based practice. So I think it's important to, to talk about what PSR services are from a scientific point of view. And what we know is that there are 3 categories from a scientific point of view of PSR services. The first is evidence-based practices, and supported employment is one of those, and that's what we'll be mostly talking about today. The second category is known as promising practices, and the third is a category that I like to call supporting services, because they are the other range of services that really do facilitate people learning how to get along and enjoy their life in the world. As far as the evidence supports them, these 3 categories of services are distinct. However, if you know the psychosocial rehab services, you know that you find many components of each of the services in many of them. So It isn't that each service has, one list of components and then the next service has a different list. There's quite a bit of overlap. So again, what are evidence-based services? And we know from research that certain interventions work, meaning they help people achieve the things they want to achieve for themselves. But to be categorized as an evidence-based practice, it has to be based on a substantial body of research evidence. And the reason I put substantial in bold is because a lot of individuals often will say, oh, well, this is an evidence-based practice or that's an evidence-based practice. And sometimes there is a whole lot of evidence to support that practice, and it might very well be what could be called an evidence-based practice. But other times, there is not a lot of evidence. There might be one study. The quality of the study might not be very great, but maybe it's been published somewhere. And because of that, someone will say, well, I know that this is an evidence-based practice. But I think we really do need to be careful when we categorize or when we call something an evidence-based practice, because it really does have to be based on a substantial body of research evidence. What we also know is that an evidence-based practice will work when it is delivered as designed and researched. And this is called adhering to the practice with fidelity. And we'll talk about fidelity later in this presentation. Fidelity is really, really important. And there are 8 evidence-based practices that have been officially identified, and they are really now the gold standard for helping people with serious mental illnesses. And they have been identified through a study which has been actually ongoing for more than 10 years. It is in its second, actually going on its third iteration, and it is known as the Schizophrenia Patient Outcomes Research Team Study, or the PORT study. And supported employment is one of the evidence-based practices identified from that review of the literature. So what are some of the findings of supported employment? First of all, it's one of the most researched evidence-based practices. And you all know, as well as I do certainly, that the majority of people with serious mental illness want to work. This is consistently identified by people as one of their top priorities. And what we know from the research on supported employment is that when supported employment programs are implemented with fidelity, the majority of those who want to work can be successfully employed. Now, that doesn't mean that they may secure and hold a full-time job. They may not want to work full-time, or they may not be able to work full-time. But the majority of those who want to work can be successfully employed using the evidence-based practice of supported employment. Supported employment is designed to help people find the right fit between their capabilities and the marketplace. So this means, what is it that they want to do? What do they see as their abilities? And what is the marketplace looking for? Another thing that we know is that becoming work ready is not necessary. So it is not necessary. In fact, it is a hindrance to spend lengthy periods of time trying to, quote, help people become ready to work. Most of us can succeed without the work-ready programs that we all used to think were very important and we used to provide for people. What are some of the benefits? First of all, increased self-confidence. If you think about yourselves, and I know this is true for myself, in our society, working is really something that often we view as very important for our self-esteem and our self-confidence. And people with serious mental illness are no different. And when we are not working, we have a tendency to think, gosh, what's wrong with me? Why am I not working? Everybody else is working. When you think about it, when you meet someone, one of the first things that you ask someone after, oh, what's your name? It's, and what do you do? And so when people with serious mental illness are introduced and meet someone, they get asked that question as well. And so actually having a place to go in the daytime is important, and being wanted and being needed is important for people with serious mental illness, just as it is for you and for me. Another benefit, of course, is improved financial position. We make money when we work, and sometimes symptom improvement, although it's important to recognize that supported employment is not designed to improve symptoms, but sometimes that helps. And what the research has shown us is that there are no adverse effects of supported employment programs or from working. So what are some of the characteristics? First of all, there is a focus on competitive employment. There is a rapid job search, which is at a pace that is comfortable for the individual. So it does not mean that people are expected to be thrown into jobs, but it's fairly quickly that people can begin looking for work when they're comfortable doing that. And jobs that they should be looking for should be tailored to their desires and their capabilities, and not tailored to the desires or wishes of the vocational specialist that's working with them. Part of the evidence-based practice in supported employment is that there is one vocational specialist to no more than 25 people that they are working with. Another characteristic is that there is ongoing support for people. It is not time limited. In fact, the next bullet says that supported employment programs are time unlimited in terms of follow-along supports. Because if you think about it, both for yourself and I know this is true for me, when I'm working, oftentimes I need somebody to talk to say, gosh, this happened at my workplace. I'm not sure what that means. Can you give me some guidance? And so vocational specialists who work in supported employment programs are there to give time unlimited follow-along supports. We also know that there should be no impediments to someone coming into a supported employment program. So substance use is not an impediment. Someone's symptomatology or diagnosis is not an impediment, and the person's work history or lack thereof is not an impediment. Another characteristic is that supported employment staff participate in the clinical team meetings and vice versa. It's highly important that vocational specialists and clinical individuals work as a team, because it's important that everyone know what's happening with the individual. I'm actually in favor of having the people in the program participate in their own team meetings as well, because I know that I don't like it when a bunch of professionals talk about me and I'm not present. I want to know what's going on, and I, as an individual, I certainly have a right to know what's going on with me and my health and my progress. So the next bullet is essentially the same thing. There's an integration of vocational and mental health services. And we said before, the focus is on real world jobs, either full or part-time as the person chooses. And there are 0 exclusion criteria. No one is screened out because that person is thought to be not ready.
Yeah. Quick question.
Okay.
So we have a question from Doug, which says, wondering how the integration of the teams can be facilitated. So what steps can be taken? I'm also just going to pop your volume.
Okay. Yeah, okay. Okay, all right, okay, so we were adjusting the volume there. I normally have a really loud voice, so. um, yeah, so that, I mean, that's actually a good question, but it's also a very difficult question because, I mean, part of the evidence-based practice is that there is an integration of the clinical team and the vocational team. So if there is resistance from the agency or from the clinical team or from the vocational team, for that matter, and there is resistance to having everyone participate, then in fact the evidence-based practice of supported employment is not being provided with fidelity, because that is a critical part of it. So, to answer the question, what can be done to facilitate that? Talking to people about the importance of everyone knowing, what's going on and how everyone's doing. The worst thing that can be done, not only for this practice, but for any good mental health team, is to have to work in isolation. It is really important that everyone know what's going on with each individual. So the only thing that you can do if people are resistant to that is to let everyone know how important it is, and let them know that it is part of the evidence-based practice and that it's crucial to the success of the practice and to the success that the person will have. And just really encourage everyone to be willing to work together. So there's no magic bullet. If people refuse to work together, I'm not sure that there's anything that we can do other than to try to be supportive and try to overcome that resistance. So I wish everybody luck with that. Okay. Oh, so I didn't hit the right. Okay. Thanks. Okay. So the findings for supported employment have only been sustained when the characteristics of the practice have been implemented as it was researched. And to go back to the question that was just asked, this is why I say that integration of the clinical and vocational teams is a critical part of the evidence-based practice. So, as part of the answer that I gave, I said, you're really putting at risk the success of the practice and the success of the person. And that's because what we know is that, if the practice isn't implemented with fidelity, adhering to the characteristics, then the likelihood of success is diminished. So supported employment, like several of the other evidence-based practices, has a fidelity scale that helps programs determine how well they're adhering to the evidence-based practice, and we're going to talk about that in the next couple of slides. The fidelity scale itself was developed by the researchers who designed the supported employment toolkit, and I'm going to give you a reference to that toolkit. And it has been proven to be very helpful to programs who want to deliver supported employment as an evidence-based practice, as it was designed, developed, and shown to be effective. So we're now going to we're just going to go through this very quickly because there are 3 slides with the fidelity scale on it. And the asterisk there is because this is copied directly off of the SAMHSA website, which is where the fidelity scale and the toolkit resides. So the first thing, and we've mentioned a few of these already. The first thing is that employment specialists manage caseloads of up to 25 individuals and no more than that. And that's quite important, as all of you know, because of the issue of time unlimited support and oftentimes this can be quite intensive, so it's really important. All of these are very important. Vocational services staff provide only vocational services. They are not asked to do 10 other things. They're not asked to be case managers. They're not, they're asked to be part of the supported employment team only. Each employment specialist carries out all phases of the vocational service, and there, as mentioned earlier, there is an integration of the rehabilitation component, meaning the psychosocial rehabilitation practice of supported employment, with mental health treatment. And as we've said before, it is crucial that employment specialists are part of the overall mental health treatment teams, and that there is shared decision making as a part of the practice. Employment specialists function as a unit, and as we said before, there are 0 exclusion criteria. There are no eligibility requirements for entering the supported employment program. When an individual says, yes, I want to work, and yes, I'd like to be part of the supported employment program, the acceptance should be automatic.
Question on caseloads from Bonnie, who wonders if the 1:25 ratio is applicable across the spectrum of vocational services, job discovery, development, and support.
As long as it's part of the supported employment program, yes. Yes. So, yeah, okay. Okay, so the next slide then is a continuation. And the first bullet says ongoing work-based assessment, meaning that vocational assessment is an ongoing process. And this involves talking to the individual, and again, this is why I said several minutes back that I really believe that people in the program should be part of the team meetings that are taken, that go on about them, because their feedback is really crucial. As a professional, I'm really not competent to say how somebody else is feeling about his or her success in a program. I need to hear that from the person, and I would really much rather have that person communicate that to the whole team rather than it being filtered through me. I also think it's much more respectful to have that person really speak to the team. So in my view, the individual who is what we sometimes call the consumer should be an integral part of this whole team effort, which is really designed to help this person be successful in the work environment. The next bullet says rapid search for competitive jobs. It should begin quite soon after the person enters into the program. But again, it really is when the person wants to begin that search. And so there is also, a lot of discussion with the individual, because certainly I have experienced lots of anxiety, and probably most everybody on this call has as well, about looking for jobs. Am I going to be successful? Am I qualified? Am I ready to do this? Is this something I really should be doing? So, people are going to be fearful. I know that I am when I've had to look for a new job. And so sometimes it's best to jump in, but the individual also has to be ready to do that. And that's where the employment specialist comes in. That's where the support in this program comes in. The next thing is individualized job search. Well, we've already said this. So contacts are based on consumers' job preferences, not based on what I think the person ought to be looking for or ought to be doing or is capable of doing. It really is, again, this goes back to respect and the individual being part of the overall team. It is really based on what the individual believes that he or she wants to do and wants to try doing. The next thing is employment specialists provide job options that are in different settings. So there should be a wide range of opportunities that individuals can begin looking at and can begin to seek out. And the next thing says employment specialists provide competitive job options that have permanent status. So again, this is not, supported employment is designed to help people find work in the real world. So that's why they're called real world jobs. It isn't temporary jobs or supported jobs in the sense that, an agency is paying for this. This is really, supported employment is designed to get people into the real workforce. So, yeah. And then I think this is the last slide that talks about the Fidelity scale. And so the next thing is jobs as transitions. Employment specialists help people end jobs when appropriate and then find new ones. And again, this is a big piece of the support that vocational specialists are providing in a supported employment program. I would venture to say that each and every one of us on this call, certainly myself included, has come to a point when we say, this really isn't working out. It's time for me to transition. And the same is true, well, as I said, for every single one of us, I would venture to say on this call, and it is certainly true for people with serious mental illness as well, who are, in fact, at the end of the day, no different than you, than me, than anybody in this room with any of us. So, everyone goes through this. We all come to the point where we say, you know what, it's time for me to move on. And so this is but for most of us, this is a difficult period. And this is partly why the unlimited support is important in supported employment programs. So, and we've just kind of said this as well for the next one, follow along supports. Because of the small caseload, individualized follow along supports need to be providers both to consumers and to employers. Again, on a time unlimited basis, when people are working, oftentimes problems come up. I know that when I have had various positions, there have been problems. And boy, I wish somebody had been there to help me navigate those problems. I could have used supported employment. That is for sure. So, people with serious mental illness can certainly use the support, and employers can be helped to understand why sometimes they need to provide additional support as well. Vocational services are provided in community settings. So this isn't something that is just provided in isolation, but these services are provided in the community. And the final part of the Fidelity scale is assertive engagement and outreach. Employment specialists make multiple contacts. Again, this has to do with the high level of support with consumers as part of initial engagement and at least monthly. Again, on a time unlimited basis, and especially when consumers stop attending vocational services, it is important. In fact, it's essential to continue following up. And then you'll see there the website, so you can find the complete toolkit for supported employment on that website. So please feel free to seek that out. And Matt is raising his hand, which means I need to keep quiet.
No, we just have another question. So Doug asks, typically, what percentage of clients require an extended period of assertive engagement and outreach, for example, beyond 6 months? There is sometimes a fear that we are harassing individuals who simply do not want service any longer.
Yeah, and that's of course true. I mean, if someone says to you, I really do not want to be engaged, I think it's important to try to continue to follow up, but obviously not against someone's wish. If if the person is really clear and you feel that this person really doesn't want services, then I think it's time to back off. Obviously, we all have free choice, and if we no longer want to be engaged or part of a system, then I think that has to be respected. I would encourage everybody to, do everything you can to try to make people feel like they are not a burden, like, this is what you as the provider want to be doing. But certainly if someone says, I no longer want to be engaged with this, please don't call me again, then, it's most likely time to back off. Although what you could do is try in another 6 months and say, how are things going? I know you asked me not to bother you, and I want to respect that. But, is there anything we can do? I don't want to abandon you. So is there anything that we can do? And if the person says, no, don't call me, again, you have to use your own judgment. So the question was about percentages. I really don't have a percentage of people who say, I no longer want to be involved. So I think, you have to kind of play it by ear as you go along. So, yeah, okay. So let me go on. Yeah, okay. So what is Fidelity? I've mentioned Fidelity and we've talked about the Fidelity scale and the components of the Fidelity scale. So really, what is Fidelity? So, and I will say, I'll give you a disclaimer at this point. I'm really a bugaboo about Fidelity, and Regina and Matt are laughing because I think they know this to be true about me. But when providing a service that has been researched and shown to be effective, it is extremely important to provide the service exactly as it was developed and researched and shown to be effective. If you or your agency attempts to provide the service but doesn't do so exactly as the practice was designed, developed, and researched, you're not providing the service that you say you're providing. You're essentially providing a different, a new, untested service. And the problem with this is that there is absolutely no reason to believe that the new service will be effective. There are no data to support the idea that whatever you're providing will be effective. You're providing something that hasn't been researched, that hasn't been shown to be effective. The reason I'm such a bugaboo about this is because providers or their agencies oftentimes, and I realize that many of the evidence-based practices, including supported employment, are resource intensive. And so agencies often get to the point where they say, well, we don't have the money to really do this, but we'll provide supported employment. We just won't do X, Y, and Z. We'll do it some other way. But the real difficulty with that is that in most cases, well, in all cases, you're not providing supported employment, even though you're calling it supported employment. In most cases, the practice won't be effective. And the issue is that clients then lose hope, they lose faith, they've been led down the primrose path of thinking, well, I'm really going to get help and I'm going to be helped to be able to work. But there's no reason to believe that they will be. And when the practice doesn't work, not only are clients disappointed, but they lose faith, they lose trust, and administrators in the program also say, well, you know what? You guys told me that this was an evidence-based practice and that this was going to work. Well, I don't see the clients working. And the reason is, in most cases, because the practice wasn't provided, wasn't delivered as it was researched and shown to be effective. And Matt is raising his hand.
We have a question from Vicky in Terrace.
Okay.
It's about external validity for some of this research. So the question is, what about the fact that a service that's implemented is dependent on the service location offered? For example, research-based may be done in a large city and then put the same practice in a small town and it might not be realistic. So how do we address stuff like that?
As far as the evidence-based practices go, the ones that are discussed in the PORT study, all of those have multiple studies in multiple locations, and supported employment, for instance, has been delivered, researched, and shown to be effective in countries all over the world. So, the practice can be delivered anywhere. The issue that I see in small communities is resources. That's an issue everywhere. We see it here in Vancouver, we see it in big cities, we see it everywhere. But oftentimes in small communities, that's even a bigger issue. So that's what I see as more the difficulty. As I said, the evidence-based practices in the PORT study have been studied in multiple locations, and supported employment, 3 of them particularly, supported employment, family psychoeducation, and assertive community treatment have been researched in, I couldn't even begin to list how many countries all over the world. So, sorry?
And rural and urban.
And rural and big cities as well. So that shouldn't be an impediment, but resources often are. So, okay, so let me go on. Okay, so another thing. This is not stated as a part of the Fidelity scale for supported employment, but this is another thing that I have a really big bugaboo about. And the reason I feel strongly about these things is because I've seen so many agencies where shortcuts are taken. And who suffers as a result of that? The people that we're trying to help are the ones who suffer. So this next slide is about appropriately trained staff. Many of the evidence-based practices require that the people who deliver those practices are appropriately trained and supervised, I would say. But what happens in a lot of locations is that, again, this goes back to resources, but an agency will say, well, you know what, we don't have the resources to hire someone who is an expert, who is really adequately trained in a particular service or practice. And so you, Susie, or you, John, or you, someone, you're going to be our person for this. And we're going to send you to a half-day training, and you're going to be our expert. This is not an adequately trained individual. And furthermore, we don't really have anybody who's adequately trained. So, you know what, Susie or John, you're going to get supervision from your team leader, who also isn't adequately trained. So again, in order to deliver a service as it's supposed to be delivered, we need to have people who are adequately and appropriately trained. And then we need to have good supervision in order to help those people when they run into problems. Because everybody, myself included, runs into problems. And we need to have supervision there. So let me go on. I think I talked about that one enough. Yeah, okay. The next thing is integration and coordination of services. And I'm looking at the time here. I probably need to move on. But I'll just go through this quickly. Ideally, one person or one team should be responsible for providing all services to any given individual. But most often, this isn't the case. You can see the classic example of this is mental health services and substance abuse services, which are almost uniformly provided by different teams. And as many of you probably know, the difficulty with that is that oftentimes these teams don't talk to one another. Sometimes there are different funding sources for different services. And so when they don't talk to one another and they don't work together well, and they're not integrated, one hand doesn't know what the other hand is doing. And what you end up with oftentimes is fragmented services that sometimes work against each other, sometimes have competing or conflicting goals, and sometimes this becomes a destructive force which impedes rather than facilitates recovery for the individual. I put on this slide, this is a systems issue because obviously one provider can't change this, but it directly impacts on the effectiveness of the individual services. So this is important to keep in mind and to encourage in the agencies and the teams that you work in that things really do need to be coordinated. And I won't beat the next one to death, but services really do need to be tailored to the wishes and goals of the individual. So the person should be expressing a desire for services. The individual, him or herself, should be setting goals. It shouldn't be my goals or your goals or what I think the individual is capable of achieving. It should be the goals that the person expresses. There should be a comprehensive rehab assessment of the individual's capabilities and resources. And of course, all of that is shared with the person. And again, the services should be tailored to the wishes and goals of the individual. Okay, let's talk for a bit about cognitive remediation and social cognition. And I wasn't asked to talk about this. I was only asked to talk about supported employment. But what we're increasingly learning, and this is in some ways, fairly new, although the research into these two things has been going on for a few years. But what we're increasingly learning is that the provision of services aimed at improving cognitive functioning and social cognition are really crucial to all psychosocial rehab services. So, and as I'm sure all of you know, both executive functioning and social cognition are often substantially impaired in schizophrenia and in other serious mental illnesses that have psychosis as a predominant feature. As I just said, there is an increasing body of literature on both cognitive remediation and social cognition, showing that incorporation of interventions targeted to these two areas enhances the impact of other PSR interventions, including supported employment. So, and Matt's raised his hand.
We've got a flurry of questions if we have some time.
Okay, should I go on or do you want me to ask them now?
Well, maybe I'll pose them and then you can reply to them as extensively or as minimally as you feel appropriate.
Okay.
First question is just whether you're able to comment on the difference between formal supported employment services you're describing here and those employment services that have been traditionally provided through clubhouse programs.
Yeah, I mean, some clubhouses, if they are real clubhouses, I won't get into that, but there are, I mean, as probably some of you know, the clubhouse movement started back in the 40s, and actually clubhouses that adhere to a certain model have been shown to be quite effective. They are not yet an evidence-based practice, but they've been shown to be quite effective. And many clubhouses actually incorporate the evidence-based practice of supported employment. I forgot the question. What was the
Well,
question?
there's the difference between supported employment services provided in that model or in Clubhouse. So like what I hear you saying is that clubhouses that follow the ICCD structured model that are evidence-based likely will be following evidence-based supported employment and conversely maybe not.
Yeah, hopefully they will be. So, yeah, so, so some do and some don't. A good clubhouse will. So, yeah.
Next question is from Bonnie regarding the goals. And so this was about tailoring goals to the interests, needs, and wishes of the individual. And the question is, what if the job seeker doesn't know what they want to do or what they can do? And so therefore, how directive can the supported employment specialist be in order to help them find areas of interest?
Yeah, okay. Well, one of the first bullets on that slide was that the person would undergo a thorough rehabilitation assessment. And it is in that assessment process that a person, it's a comprehensive assessment. So the person identifies his or her wishes, that person's abilities are identified. And then, this isn't a quick and dirty kind of things. It's a process that takes place. And again, it involves the individual. So it isn't that you come into my office, I give you a few tests, and then I make some determination. All of this, it's a process that must involve the individual. So it isn't just, it isn't just me deciding what the person wants to do. And everybody, no matter what kind of illness we have, all of us are capable of saying what we want to do. Now, as a vocational specialist, your job is to help that person, but not to answer the questions for the individual.
Follow-up question to that one is then who is doing the rehab assessment generally on these teams?
Yeah, there should be somebody who is trained in doing a thorough rehab assessment. So a person like an occupational therapist, for instance, would be a good person to do that. Or somebody who has gone through training, thorough training. There are some locations that provide a training in how to do a rehab assessment. As a psychologist, I'm not trained to do a vocational assessment. So let me put that right out there. But Regina, who's in the room, is trained to do that. So some of us are and some of us aren't. So yeah.
So maybe I can just give a plug to 2 past webinars that are on this particular website, one of which is on person-centered care and the other is on assessment. So there are long webinars that may give some detail around specific steps for assessment.
And then in the interest of time, I think we got to move on soon, but there's one more question. It's just around the specifics of training, the supported employment specialists. And the question is the research specific about what training or skills are needed?
For somebody for vocational specialist. Training in vocational counseling, training in vocational assessment. It wouldn't, to go back to my earlier example, it wouldn't be, okay, Susie, you're now our vocational specialist. It should be somebody who actually is trained, because all of these professionals, all of these occupations, I guess you should say, occupational therapy, psychology, vocational counseling, employment specialists, there are actual training programs for all of these occupations. And I will beat a dead horse here. So to go back, to what I was saying, the difficulty is that all too often in our community agencies, and again, I understand this is with, the best of intention and due to resources, but all too often people are designated. I've seen this, with cognitive behavioral therapy. This is another big bugaboo of mine, for instance. CBT is a psychotherapy. And yet, how many times are people who have absolutely no training? They are not qualified. They are not registered. They're not licensed as whatever professional to provide psychotherapy. How many times are they not told, okay, you're going to be doing the CBT program? It's just one example. So people need to be trained. And Matt is shaking his head, basically telling me, move on, lady, move on.
And maybe it's Regina. I'm just going to add one thing, but we have made reference to the Advanced Practice for Employment website, and I know that their work is under development, so they have really tried to collaborate with the employment community, meaning people delivering services, to, I think, help identify their needs. So my understanding is that they will likely be able to articulate more clearly what some of that assessment training that's needed within the community. So we'll look forward to that, and I'm going to ask just Matt to find that website. So give me a moment, and I'll post that.
Okay, all right. So I'll go on. So what is cognitive cognitive remediation? Cognitive remediation interventions are aimed at improving the components of executive functioning, meaning cognitive processes such as impaired thinking ability, working memory, reasoning, task flexibility, and problem solving, as well as planning and execution of tasks. So these are, executive functioning tasks within cognitive functioning. Cognitive remediation interventions typically use computer-assisted learning programs aimed at improving executive functioning, meaning improving learning, memory, attention, concentration, and other components of executive functioning. So what is social cognition? Social cognition includes affect perception, meaning can I figure out what another person is feeling? So, if someone is in front of me and looks really sad and is, really downhearted, can I tune into that? Social cue perception, empathy, attributional style, and theory of mind, or the ability to make attributions about a person's mental state. So all of these, this is the social component to our thought and feeling processes. Social cognition interventions are aimed at teaching people skills. And what are those skills? Those skills that are needed to deal effectively with difficult social situations and make better attributions about what people are thinking and feeling. Social cognitive interventions usually incorporate didactic teaching, modeling, and role-playing, focused on helping people build social competence and positive social interactions by enhancing communication skills. So social cognition is a skills training program, but it's aimed at social capabilities, communication skills, attributional abilities, affect recognition, and so on, whereas cognitive remediation is also a skills program, but it is aimed at our executive functioning, meaning learning, memory, and so on. Okay, I don't know if this is the last slide or not, but let's talk just for a second about the need for comprehensiveness. Because of the importance of executive functioning and social cognition, it is really important to incorporate both of these interventions with other psychosocial rehab interventions. And research is increasingly showing how important these two components are to be added to whatever other PSR interventions are delivered. It is also becoming increasingly clear that providing individual interventions, whether it's supported employment or any other individual intervention will have little effect. Comprehensively designed packages of PR services, again, based on what the individual's wishes and goals are, we're learning increasingly that it is important to design this in concert with the individual. Shouldn't be me putting a package together and saying, okay, here's what you need. But together with the individual, we're learning that this is increasingly important. So services should be comprehensive. So this is probably the last slide. So what are the summary and conclusions? Everybody with mental illness has the potential to recover and achieve a maximum degree of self-sufficiency. Let me just say a word about what this means. It doesn't mean that everybody is going to recover to the extent that that person will work full-time, will live independently, or whatever your standards or my standards might be. But it does mean that everybody has the potential to recover and achieve whatever that person's maximum degree of functional capability and self-sufficiency would be. The second thing, the primary focus of psychosocial rehabilitation is on improving the capabilities and the competencies of people with serious mental illness. Psychosocial rehab interventions are not aimed at changing symptomatology, although many of our PSR interventions actually do end up helping to improve symptoms. The third thing, supported employment is one of the most researched and effective PSR interventions, but that is only when it is provided with Fidelity. The focus is on competitive employment, intensive support, and zero exclusion criteria. Cognitive remediation and social cognition training, it is increasingly clear that these two components are really important and that they should be provided with other PSR interventions. And well, I said already about providing the evidence-based practices with Fidelity, appropriately trained staff, and in an integrated manner. And finally, it is important to design a comprehensive set of psychosocial rehabilitation services for each person. And that's it. That's the end of my presentation. Okay, and Regina is coming here.
I'm coming beside Mary to say a big thank you to her for such a stimulating presentation. Your clarity is deeply appreciated, Mary, and just the depth and the breadth of your knowledge. We've certainly gained much from that, so thank you.
Thank you, Regina.
Mary, I have a question for you just before other questions come in. And part of what we're trying to accomplish here, so this, you'll remember, is a grant from Ministry of Advanced Education. And so Douglas College has taken a little bit of a unique approach to developing workshops in this area. And so we've really tried to focus on providing employment services for people with complex needs. And so one might perceive that, that some of the work we're trying to accomplish is perhaps outside the regular, people who live with mental health issues, that area. So we're trying to accomplish for people who maybe have autism or multiple and complex needs. So mental health, addiction issues, and several other issues perhaps. And I'm wondering if you can comment on how, give us advice perhaps, or maybe just make some reflections on, does this change the intervention? Does this change what we're advocating for? Or if you have other comments in that area. So I guess just essentially, perhaps we're trying to do something that's even more complex, perhaps, or perhaps not. And just if you could comment on that, I'd greatly appreciate it.
Yeah, for sure. I think that adds to the complexity and changes the picture. It's important to note that the evidence-based practice of supported employment was developed and researched for people with serious mental illnesses. The study populations were not people with autism, or I can't remember what other group you might have mentioned. So I don't have any way to say, well, because I think part of your question is, well, is this going to work with those populations? And I don't have any way to answer that question. So, it might be worth trying it. I'm not saying not to try it. I would definitely say if you do, stick as closely as you can to the fidelity of the practice. And particularly as the needs of the individual become more complex, you're probably going to need smaller caseloads. You're probably also going to need other specialists involved, people who know about autism and people who know about whatever other issues are going on. I would also say collect data because, when it works, it would be great to know that, although you have to be, you really kind of have to know what you're doing, to really be able to say that. So yeah.
Thank you.
Okay, so a question from Christine LaForge that says, should we do less or no transitional employment and more supported employment with Fidelity? With limited resources, we make choices, but what we do and what we do not do.
Yeah, that's an excellent question. Transitional employment has not been shown to get us anywhere, to be effective. You asked for my opinion. Should we do this or should we not do that? My opinion would be to do more of, to do supported employment with Fidelity. And again, I would go back and say, never say you're doing supported employment if you're not, adhering to the fidelity of the practice, because then you're not doing supported employment. But yeah, transitional employment has not been shown to be effective. So I'd go with what's been shown to work.
And just a couple more questions I think are coming in right now. So if we have just a few more minutes to wait while some people throw in their ideas, and then we'll close for today.
So when they're coming in, what does that mean? People are typing.
Yeah.
Oh, they're typing.
Maybe just a reminder to folks while some people are typing questions that all the past webinars are available on archive on our website at www.psyrehab.ca, and that we have one more session coming up as part of our special employment series that's going to be taking place on Friday, February 27th. You can register for that one. There are a few seats left, not many, but a few seats left. So get in there quick if you're interested in that session. And that's with Catherine Newstead. And we'll be promoting the IPS model. So the question here from Sally says, one of the biggest barriers to adhering to Fidelity in order for supported employment is the current system structures and resources. Any advice on how to address this, which you have. You've mentioned that, but addressing it maybe is a little bit more of a difficult question. Yeah.
I don't have a magic bullet. Let me say that right up front. This is the resources issue is something that every agency, every team, every provider group struggles with. The thing I would say, is we can't be all things to all people. And so I'm going to say something that's probably going to sound a bit conflicting. I said earlier in this presentation, it is really important to provide a comprehensive range of psychosocial rehabilitation interventions. But I realize that isn't always possible. I'll put a pitch in here for something else, and that is, I think we all also need to become advocates. A big problem is that mental health is not provided the resources that are needed. And I have long been of the opinion that people who are consumers of mental health services and providers of mental health services, as well as agency administrators and everybody else, really need to become much more involved in the politics of funding mental health services. You all know the saying, the squeaky wheel gets the grease. Well, we are not typically and traditionally squeaky wheels, and yet we really do need to be. So, I don't even remember what the original question was, but it's about resources. And, no service provider has enough resources. But I think we all need to take responsibility for becoming more active advocates.
Great answer. And our last question for today, before we close, we'll get to Andrian, who asks, how are cognitive and social remediation programs different from work-ready programs or services? So I guess what's the difference in this context between cognitive social remediation, which I'm not too familiar with, and pre-employment or prep services?
Yeah, well, I mean, there are, as I said, one of the very first things I said is that, there is often overlap in many of these things. But cognitive remediation specifically uses computer programs that have been developed specifically for that purpose. So cognitive remediation programs help people to train their executive functioning capabilities, meaning their memory skills, train people in how to learn and remember. And so, they are computer programs that, and there may be cognitive remediation programs might be a part of supported employment programs, not the original evidence-based practice that was developed, but certainly should be incorporated along with a supported employment program. The same thing with social cognition. Social cognition training helps people recognize other people's emotions, basically. So if I'm talking to someone and that person is laughing, I need to be able to recognize that that individual is happy. Or if someone's telling me a nice story, I need to be able to recognize that that person is feeling good about something. So social cognition programs help individuals develop those skills. And instead of being done on a computer, those social cognition programs are done using, can be one-on-one or group training, but it's, as one of the slides in the presentation said, there is didactic teaching. So in other words, people are given information. Didactic means informational presentations. And then there are modeling, meaning the trainer will do role model presentations to show somebody, well, here, look now, John has just spoken to me and I can see that he's smiling. So that must mean that he's pleased about something. And after that, then the individuals who are being taught how to recognize affect then will have a chance to practice those skills. It's really good if those interactions can be filmed, because then you can play them back for the individual and say, now you see here, if you look at John, you see that he was smiling and looked pretty happy, but you didn't pick up on that. So anyway, there's lots of repetition in all of that, the role playing that goes on. So I don't know if I always lose track of these questions. I probably missed it again, but
I'm wondering if one of the key differences is that one doesn't take place exclusively prior to finding work.
Oh no.
So it's really a question of timeline. One, the cognitive remediation and social remediation are more of an adjunct to the.
And they're all done. They should all be done together. Yeah, absolutely.
Yeah. So just the big thing, application to function as opposed to done in, so they're more generalizable, the information.
Absolutely generalizable. Yep, 100%.
Okay. Wonderful.
Super.
Oh,
Yeah.
so okay. Well, let me just thank everybody for being a part of this. I've enjoyed doing it. I hope it's been helpful to to some. And again, thank you to Regina and Matt for inviting me and for all of the help that you've given me.
So thank you again, Mary. Thanks to everybody. We wish you a happy Valentine's Day tomorrow, and we look forward to seeing you in 2 weeks. Bye for now.
Bye.